Friends, so today we are here to discuss a very logical and interesting concept of spine orthopedics. We are going to learn the art of writing the MRI report before getting the MRI done. Jokes apart, today we are here to understand the art of reaching to the provisional diagnosis, just the spinal way. Often on in OPD, we are confused between few of the common differentials we encounter in a spine OPD, that is lumbar canal stenosis, prolapse intervertebral disc, osteoporosis, vitamin D deficiency, cervical myelopathy, listhesis. All these concepts, all these differentials, we often get confused between what actually is the patient all about using our examination and history taking. So today what we are going to understand is we are going to understand how to clinch bang on to the provisional diagnosis using history and examination even before getting the radiological investigations done. So without further ado, let us begin with what our plan for today is. We are going to discuss the basic history and examination. We are going to understand the basic history and examination and significance of each and every question and test performed. Each and every question asked in history has some significance, and that is what we are going to discuss today. We are going to understand the points favoring the differentials, all four to five differentials of spine, low back pain, the radiculopathy. We are going to learn how to reach to the provisional diagnosis using logical flowchart method, using very logical methods and understanding to reach to the provisional diagnosis. Then we are going to understand the basic management protocol for each diagnosis when you see the patient, when you clinch the diagnosis in OPD, and how do you go about the investigations in spine. And at last, the most interesting part, we are going to go to the spine OPD and we are going to practice 4 to 5 OPD patients, 4 to 5 cases, and how do we clinch the diagnosis, how do we learn the art of reaching to the provisional diagnosis. So without further ado, let us begin with the basic history and examination. Each and every point has a significance. I am going to discuss in brief in the beginning, in the basic history and examination section, and then we are going to discuss in detail about each differentials. Okay, so this I have taken one of the examples about a case. She is a 65 years old lady. The age and the sex is very important. When the age is more and it is old age female, you are likely suspecting a osteoporosis. If a postmenopausal lady is there, she is 10 years postmenopausal, so more of osteoporosis picture, more of LCS picture, right? So this is age and sex is very important. No known comorbidities. The comorbidities, if there is diabetic or hypertensive, it might associated with the pain or diabetic neuropathy, nephropathy, all those things. So comorbidity is very important. Age, sex, and how many years postmenopausal. Additionally, the occupation is very important. Let's suppose you are dealing with a person doing a corporate job, less exposure to sunlight. You are suspecting a vitamin D deficiency. The patient who has come to you is a laborer and he has a history of lifting heavy weight. You might be suspecting a PIVD. So all those things we are going to discuss in detail. Just this basic, I am giving you a brief idea of why all these questions we ask in the history are important, right? Then we do ask the diet, pure veg diet or non-vegetarian diet, mixed diet. Pure veg diet, you are looking at a picture of vitamin D deficiency. So, right, so this is the basic demographic detail. In the demographic detail, the basic we are able to look at the picture, what it is, whether it is a LCS, osteoporosis, just we can have a basic idea. Now, the first question you ask is the presenting complaint. So this lady she is having low back pain with bilateral low limb radicular pain since 5 years, which has aggravated since 2 months, right? And you have to ask whether the low back pain is more bothering or the radiculopathy is more bothering. So whenever there is radiculopathy, you might be suspecting, you have to suspect a nerve root compression, you have to suspect a PIVD or LCS picture. And whenever there is plain low back pain, so you have to ask whether there is low back pain or bilateral lower limb radiculopathy pain or both, and which is more, so that you can reach to the diagnosis. We are going to discuss in detail what signifies what, right? This is the first question, the presenting complaint, right? Now the second question is the aggravating factors. How does the pain increases? So this lady, the pain increases on walking and prolonged standing and gets relieved on the sitting position. So this is more of the pain is increasing on walking and prolonged standing. So you have to ask which pain, low back pain or lower limb radiculopathy pain. right? So this is more of a neuroclaudication picture. The pain increasing on walking and prolonged standing is more of a neuroclaudication picture that goes to the idea, that leads to the idea of LCS. Don't worry, we are going to discuss in detail each and every differentials. This is just a basic idea. So when there is neuroclaudication, you ask what is the walking time after which the patient has to sit due to pain, what is the standing time. This will give you the severity of neuroclaudication, the severity of lumbar canal stenosis, right? And additionally, let's suppose this patient presents to you after 6 months, so you can know the progress of LCS. If the walking time is reducing, if the standing time is reducing, or the patient himself or herself says that 2 years back I was able to walk for 5 kilometers and now suddenly since last couple of months I'm not able to walk for 5 minutes as well. This is an aggravation of LCS picture, right? So this is very important. Now, additionally, the few of the aggravating factors, like let's suppose this lady is having pain increases on in bed turning and sitting from sleeping position. So whenever there is pain increasing on in bed turning and suddenly sitting from sleeping position, you are looking at a picture of instability. This pain is due to instability. And what might cause the instability at the spine? The picture of listhesis. The picture of listhesis might be causing instability at spine. So this is the character of pain. Pain increases on in-bed turning and sitting from sleeping position. That is because, retrograde if we think, that is because of the instability around the spine. And when there is instability, it might be a picture of listhesis. So till this point, we are suspecting a LCS type of picture with some osteoporosis. Additionally, there is a component of listhesis, right? Now, one of the very significant history point we should not miss is when the patient says that he has a pain in bending forward, in flexing or extending, or pain relief while flexing or extending. That is very specific. That is very specific. So this lady, she gets relief on bending forward and keeps her knees and hips flexed for pain relief. This is very significant history. So whenever the patient says that on bending forward, on flexing, he has pain, that is a picture of Pivd. If you imagine the spine, that is a picture of Pivd. And whenever the patient says that on flexing, the patient gets relieved, the patient feels better, that is the picture of LCS. So these LCS patient picture, the patient presents to the OPD saying that when I keep my knees and hips flexed, I feel better. Right, we are going to discuss in detail. Now, the other thing you must not miss is history of tingling and numbness present in lower limbs, right or left. That you might give a picture of radiculopathy and nerve root compression, right? Then the alarming sign, it is very important. You must not miss to ask this thing. That is history of bowel or bladder disturbances. That is an emergency. History of bowel and bladder disturbance is an emergency. So when the patient has a history of urinary incontinence, this lady is having history of urinary incontinence since 5 days. That is a alarming sign. No history of bowel disturbances. This requires surgical intervention after adequate radiological investigations and confirmation of the diagnosis. Now, Another thing from the history you can know is whether there is weakness in the foot or lower limbs. That is the history of slipping of footwear present while walking, present bilaterally. That is, whenever there is history of slipping of footwear, that does mean there is some weakness at the toes. So with history taking only, you can know whether there is some neurodeficit or not. Now, the next point, history of sleep disturbance present or not, or history of fine motor disturbance present or not, or patient is not able to do his daily job and has stopped working due to pain. This is a very significant history because his daily life is getting affected. His lifestyle is getting affected. That helps you taking the call whether you should go for a conservative or surgical management. That helps you in counseling or discussing with the patient how to go about with the pathology he or she is having, right? So history of sleep disturbances, history of fine motor like buttoning, combing, all those fine motor activities in lower limbs. In upper limbs, you ask for history of fine motor disturbances, whether he is able to write like before, whether he is able to button his shirt like before, combing and all those things. And patient is not able to do his daily job, whether is it daily life is getting affected, his sleep is getting affected. This helps you in deciding while taking the call whether to go for conservative or operative management. Now, the next thing, often on avian patients presents to the spine OPD, avian patients to the spine OPD with abnormal gait. And so how to differentiate with a single question, how to differentiate whether it is a hip pathology or a spinal pathology. You ask whether the patient is able to squat and cross leg sit. If he is able to squat and cross leg sit, you are most likely you have ruled out a hip pathology. And you are looking at a pure spine picture. Right? So and next is you ask is no history of trauma, fall or exertion. If lifting heavy weight might lead to PIVD, trauma might lead to traumatic fractures around the spine, fall in old age might lead to osteoporotic fracture. So these are the significant history you need to ask. Now this lady has a specific complaint. This lady has a specific history. History of left-sided neck of femur fracture for which DHS plating was done outside hospital 4 years back. This is not a simple history. This is a very important, very significant point. History of multiple fractures in the past. You are very likely suspecting osteoporosis. So till now, there are so many findings. Like she is a 65 years old lady, postmenopausal, pure veg diet. So according to the age, postmenopausal status, pure veg diet, you are suspecting osteoporosis, or you are looking at a more of a LCS picture or age-related degenerative picture, right? The patient also has lower limb radicular pain, which is aggravated along with low back pain. Now, history of neuroclaudication is present. History of instability type of pain, history of pain because of some instability around the spine is present. History of neuroclaudication is present, more of an LCS picture. Instability is there, so more of a Listhesis picture, right? The pain gets relieved on bending forward, flexion is relieving, flexion is decreasing the pain, more of LCS picture. History of tingling and numbness present, severity of the situation. Now, history of urinary incontinence, bowel bladder disturbances, emergent intervention. After confirming the diagnosis, emergent surgical intervention warranted, right? History of slipping of footwear, there is some neurodeficit in this lady. History of sleep disturbance present, patient is not able to do her daily activities. That does mean her daily lifestyle is affected. Okay. Then patient is able to squat and cross leg sit. You have ruled out the hip pathology, right? And history of left neck of femur fracture, history of multiple fractures in the past, more of an osteoporosis picture, right? So with the history taking itself, just a 5-minute history taking picture, you have ruled out in your mind whether it is a PIVD, whether it is LCS, there is some osteoporosis component, there is some Listhesis component. This is the subtle art of reaching to the provisional diagnosis using the history. We are going to discuss, don't worry, we are going to discuss in detail with each differentials. This was just a brief out. Right? Now on examination, first thing you look at is the gait, right? So if there is a list, it is more of a PIVD picture, right? If there is some high steppage gait, that is some neurodeficit, foot drop might be there. So ankle dorsiflexion is lost. Just with the gait, you can imagine what all neurodeficit are there. Wide base gets some of the examples I'll tell you. Wide base gait in the cervical myelopathy picture. Trendelenburg gait whenever there is abductor weakness. So these are the different types of gaits. These are the different gaits using which you can suspect the neurodeficit or what the picture is all about. Okay, so as I discussed, the gait is very important. You will get to know the clinch. You will be able to clinch the diagnosis. Next, you ask the patient to walk on heel and walk on toes. That will give you the picture of whether there is ankle dorsiflexion, plantar flexion, weakness or not. If he's able to do heel walk and toe walk possible comfortably, you might not be looking at a picture of ankle dorsy or plantar flexion weakness or a neurodeficit. Now, the next examination is very important. ROM, if the flexion or extension, what is painful? If the flexion is painful, you are more likely looking at a picture of PIVD. If extension is painful, you are more likely looking at a picture of LCS. If both are painful and the ROM is not possible due to extreme pain, you might be suspecting osteoporotic fracture or a post-traumatic fracture or stiffness. So all these are in the mind. You have to keep imagining about the reaching to the provisional diagnosis. So next is SLR test. This is very important. SLR test or the nerve root stretching or compression test. If the SLR test is positive, there is nerve root compression, there is nerve root stretching, you might be looking at a PIVD picture, right? If there is midline tenderness or upper dorsal tenderness is present, it is more of a vitamin D deficiency or an osteoporosis picture, right? The next is thumb test. If you thump on the back and if it is painful, whether it is painful or it feels better, if it feels better, it is more of a muscular pain. It is more of a muscular pain. If you thump on the back of the patient and the patient feels better with that, it is less likely a more significant pathology. It is more likely a muscular pain, right? Like PSMS, paraspinal muscle spasm, right? Next is you examine the motor power and weakness, EHL, EDL, FHL, FDL, ankle, knee, hip, and all the dermatomal you check for the weakness in bilateral lower limb or in upper limb if it is a cervical case, right? Next, you examine the reflexes, whether it is upper motor or lower motor neuron lesion. Upper motor neuron lesion seen in cervical myelopathy and all those things we will discuss, right? And then we are looking at a sensory dermatomal weakness or sensations decrease in which dermatome to know the level of the pathology, right? So this was the basic history taking. Now we are going to discuss all this. Now we are going to discuss and understand how to clinch to the diagnosis. What all points I just discussed in brief till now. Now we are going to discuss the bang-on provisional diagnosis, that if these 4 points are there, you are more likely looking at the picture of this diagnosis, right? So first and foremost is we are going to discuss a case. Whenever the patient is a vegetarian, pure veg diet, she is a post-menopausal female, 10 years menopausal, 7 years menopausal, and female. And the profession like a corporate job, corporate worker, having less exposure to sunlight. Additionally, if the patient has midline spinal tenderness or upper dorsal spinal tenderness is present, and the patient presents to you with non-specific symptoms. Non-specific site of pain is changing. Sometimes the patient says that 2 months back I had right lower back pain. Right now I am having left lower back pain. A little bit of radiculopathy symptoms. The site of the pain is changing. It is an on and off in nature, right? For 2 months the patient says that I had history of similar low back pain 2 to 3 years back. And now I'm having again pain, but the site has changed. And this patient is the patient which we are going to lead to the diagnosis, has a significant history of taking supplements in the past, following which the symptoms resolved. Often one patient says that 1 year back I had a history of similar complaint for which I had taken some supplements, and now at that time it was resolved. Now it has recurred. And these patients usually do not have radiculopathy. But if at all the radiculopathy is present, it is not significant. How do you know whether it is not significant? You ask for sleep disturbances or affection of the daily lifestyle, right? If the sleep is disturbing, if the radiculopathy is disturbing the sleep, it is more of a significant radiculopathy. So it is more of a PIVD picture, right? But whenever it is not significant, so all these factors clinch to the diagnosis of vitamin D deficiency plus or minus query B12 deficiency, right? Vegetarian diet, postmenopausal female, less exposure to sunlight. dorsal tenderness, non-specific pain, a young female, young male coming to you, vegetarian diet, and says that on and off pain I'm having, right side, left side, I've taken supplements in the past, not significant radiculopathy. These are all non-specific symptoms clinching to the diagnosis of vitamin D deficiency, often with no neuro deficit. Mostly vitamin D deficiency do not have any significant neuro deficit, right? So how do you confirm? How do you confirm the diagnosis? You will go for serum vitamin D or B12. And if you are clearly looking at a picture of vitamin D, you are suspecting at a clear picture of vitamin D deficiency, the patient is malnourished, not taking proper diet, then you can straight away start calcium and vitamin D supplementation for 3 months and call for follow-up, right? For postmenopausal females or osteoporotic fracture, we give 1000 mg calcium, and otherwise we give 500, right? And vitamin D 60,000 international unit once a week, right? So this was the first case. This was the first case of vitamin D deficiency. The next case we are going to discuss is the case of osteoporosis. So whenever the patient has a vegetarian diet, postmenopausal female, post-hysterectomy female, very significant, old age, and the most significant finding in the history which leads clinch to the diagnosis of osteoporosis is the history of multiple fractures in the past. Otherwise, you can also find patient has glucocorticoid therapy, hypogonadism, estrogen deficiency, all these things in the past. And midline tenderness in the spine or upper dorsal tenderness, you are looking at a picture of osteoporosis. Right, so how do you manage a case of osteoporosis? First thing, you go for whenever you are short, you are looking at a picture of osteoporosis, you go for X-ray and DEXA scan. Now, if the X-rays shows osteoporosis with no fracture line and the DEXA scan shows osteoporosis, you have looked at the T and Z scores. If the T and Z scores are significantly low, less than 3, it is advisable, that depends on surgeon to surgeon, but it is advisable to give a course of injection teriparatide for 3 months, followed by alendronate for 3 months, repeat the cycle for 6 months, and you can also go for continuous 1 year teriparatide injection. That depends on the surgeon to surgeon. So 1 year of anti-osteoporotic treatment is very essential. 1 year of anti-osteoporotic treatment is very essential, and after 1 year you go for a reassessment clinically and you go for a repeat DEXA scan, right? So this was the picture when there is significant osteoporosis. If the osteoporosis is not that significant with no osteoporotic fracture, the score is like -1, -1.5. If it is more than -3, you might go for bisphosphonate, only bisphosphonate, alendronate 70 mg once a week along with calcium and vitamin D supplementation. That for 3 months. Or you can call the patient for follow-up and you can reassess, and after 1 year, usually DEXA scan is done after an interval of 1 year of giving the anti-osteoporotic treatment, right? So this was the picture when there is osteoporosis in X-ray with no obvious fracture line with DEXA scan suggestive of osteoporosis. Now, if there is some osteoporotic fracture in X-ray and DEXA scan confirms the diagnosis of osteoporosis, if at all there is neurodeficit, surgical management is the preferred line of treatment. Now, if the neuro is normal, then calcitonin, then we can go for, that depends on surgeon to surgeon, but calcitonin has shown to give great relief in osteoporotic bone pains. Injection calcitonin, or you can give nasal spray. And the most important, along with calcitonin, you should not miss giving calcium and vitamin D supplementation. Giving calcium supplementation along with calcitonin is the thing you should not miss anyhow, right? And if at all the osteoporotic fracture, in osteoporotic fracture neuro is normal, if at all the osteoporotic fracture is AO type A, you can go for a conservative management over surgical management. So this was the picture when there is neuro is normal and osteoporotic fracture is there. You can go for calcitonin, calcium and vitamin D supplementation. So conservative advice over surgical. That also depends on surgeon to surgeon. Now, even after, you might directly go for a vertebroplasty, that depends, right? So even after giving this supplementation, if the patient has pain relief, and patient is symptomatically better, you can continue for calcium and vitamin D supplementation. Or you can go for alendronate. You can start alendronate depending on the DEXA score. You can follow this flowchart. You can go for teriparatide. You can also go for injection denosumab or bisphosphonate therapy, right? For 1 year you have to give anti-osteoporotic treatment, and after 1 year you go for a repeat DEXA scan. But even after giving this, if there is no significant pain relief after 3 to 4 weeks, if the patient, when you have called the patient for follow-up after 2 weeks, 3 weeks or 4 weeks, if the patient says that doctor, there is no pain relief, the pain is instead increasing, then you can go for a vertebroplasty for pain management. That is one option. But one thing you should not miss, if the pain is increasing or if the pain is the same, it does not decrease at all, then one alarming sign you should look for is whether there is some non-union or whether there is some instability. So you might have to go for an MRI to look for non-union or instability. And if there is some non-union instability, you might go for a surgical intervention. That depends on the surgeon to surgeon, right? But any day, whenever there is neurodeficit, the surgical management is always preferred. So this was the case number 2, that is osteoporosis, right? Now we are leading to a very interesting case, the third case, that is we commonly encounter in the OPD, is the case of prolapsed intervertebral disc. Okay, so there is some significant history in Pivd, right? Whenever the patient says that I have a history of exertion like lifting heavy weight, following which the pain started, this is very significant, leading to clinching to the diagnosis of Pivd. You should not forget to suspect Pivd, right? Pivd patients have very significant radiculopathy to lower limbs. Lower limb radiculopathy, suspect Pivd. That is the thumb rule you should remember, right? Now, radiculopathy sometimes is there in vitamin D deficiency also, in other picture also. But how to know whether it is significant? So it is associated with sleep disturbances affecting his or her daily life. Radiculopathy is very significant in Pivd, right? So in history, these two are points which support you, which leads you to the diagnosis of Pivd. History of lifting heavy weight, sometimes it might be idiopathic as well. But so history of sometimes lifting heavy weight, radiculopathy to lower limbs. Radiculopathy is more significant sometimes than low back pain. Now on examination, significant finding leading us to Pivd is the presence of list. Whenever the patient is walking to you in OPD, just have a look at the gait. If there is list, suspect Pivd in first place, right? Now on examination, whenever the flexion is painful, very important finding, whenever the flexion is painful, just imagine the spine. Whenever the flexion is painful, it is a picture of Pivd. Now, the nerve root tension signs like SLR and slump test, SLRT, whenever it is positive, it is more likely a Pivd picture, right? Because of the stretching of the nerve root, as the name suggests, nerve root tension sign. Now, at this stage, whenever the patient is presenting with these type of complaints, and you have suspected Pivd, right, the first thing you go for is a X-ray. And if there is some neurodeficit, if there is some weakness in the lower limbs, you can directly straight away go for X-ray and MRI, right? So whenever you go for an X-ray, what you find in a Pivd is disc degeneration, that is decreased intervertebral space. L4, L5 decreased L4, L5 decreased space, L4, L5 disc degeneration. These are the common findings, right? So the first thing, the treatment depends on surgeon to surgeon, but you can go for a short course of steroid. If there is no neurodeficit and the patient you have confirmed the diagnosis on X-ray, there is some disc degeneration, you can go for a trial of short course of steroid. You can go give prednisolone, TDS, BD, and then OD, a 9 days course, a short course of steroid. And after 9 days, you call for the patient for follow-up. If there is some relief, you can send the patient for physiotherapy, core stabilization exercises, right? But if there is no pain relief, or very less pain relief, then you should be going for a MRI for confirmation of diagnosis. And if at all you have already done some MRI, you might, the first step, you might go for a trial of selective nerve root block. If in MRI you confirm that there is a Pivd picture and there is some nodular deficit, you can go for a trial of selective nerve root block. If there is no relief from selective nerve root block, you can remove the disc. You can go for a micro discectomy. And the last step, if there is no relief with micro discectomy, also you have to go for a significant surgical intervention, that is posterior spinal fixation and fusion. So this was the picture of Pivd. Now next we are going to discuss is the picture of LCS, right? So the patient of LCS has a very classical and significant history of neuroclaudication. Patient presents to OPD and says that after walking for 5 minutes, I am having bilateral lower limb radicular pain, tingling and numbness, and I'll have to sit. And on sitting there is significant pain relief. This is the classical words of a case of neuroclaudication. Am I making sense? So you'll have to ask, this is the history you should be asking yourself, at how long can you walk without sitting? And the patient says that after 10 minutes, I have to sit. You have to ask, what are the aggravating factors, what are the relieving factors? This you'll be able to ask when you ask the aggravating factors. On doing what the pain increases. The patient might say that after walking for some time, I just came from the door to your OPD and I am started having pain. So that is a picture of neuroclaudication. You ask the walking time and the standing time. After how long you'll have to sit. After how long you are having the radicular symptoms. After how long you are having the pain, low back pain with lower limb radiculopathy. That is when you know the severity of the neuroclaudication. And it is very important to understand, because on follow-up also you can understand the change in the severity, the progress in the disease, right? And one of the very significant history the patient gives, which might help you in leading to the diagnosis of LCS, is the patient says that I feel better by keeping my hip and knees flexed. Sometimes the patient also might show you saying that if I keep my legs like this flexed, my hips like this flexed, I feel better. I always sit like this. That is significant history of LCS. Because why? That is the question. Because in ROM examination finding, the pain gets relieved by flexion at LS spine in a picture of LCS, which was opposite in Pivd. In Pivd, flexion was painful. So this is how you differentiate between LCS and Pivd, just with examination and history, right? So these are the few important things: neuroclaudication present, flexion painful, old age. These are the points leading to the picture of LCS. So once you are suspecting LCS, you go for X-ray and MRI, and once the diagnosis is confirmed, now one of the significant history you should be asking is, how much is the disease we are treating the patient? We are not treating the MRI, we are not treating the MRI report, we are not treating the X-ray, we are treating the patient. So how much is the LCS component affecting his or her daily life? It is important to ask. So if there is history of sleep disturbance, if there is a fine motor disturbance, loss of work or occupation, all those things, if his or her daily life is affected, that is what we need to ask. So whenever there is neurodeficit in a picture of LCS, straight away surgical management is advisable. Whenever there is whenever the neuro is normal, but the daily lifestyle, all these factors are getting affected, the quality of life is getting compromised, and he or she is not able to fulfill his or her daily requirement, loss of work and occupation, at that time also surgical management would be better than medical management. Depends on the patient condition, patient requirement. We are treating the patients, not the report. So depending on the patient's requirement, we might go for a surgical or a conservative management. And if the neuro is normal and it is not affecting the quality of life, he or she is getting good sleep, able to do daily work, no fine motor disturbances, no affection of daily life, you might go for a medical management, explaining all the complications of LCS, right? Now the next thing, so this was LCS. So we discussed LCS, Pivd, osteoporosis, and vitamin D deficiency, right? Now we are going to discuss, when do you suspect a listhesis component, right? So whenever there is history of pain increasing on getting up from sleeping position, or whenever there is history of pain increases on in-bed turning. This is a type of pain. The character of pain is due to some instability around the spine. And when there is an instability around the spine, when there is some listhesis component which we get confirmed on X-ray. Now the management depends upon the associated components, whether there is Pivd, LCS, neurodeficit, osteoporosis, what all. But there, using this history, you might be suspecting that there is some listhesis component as well, right? Now, traumatic spine fracture, very simple. History of trauma is there. Acute onset of pain post trauma. Tenderness at the midline tenderness present at the local junction or at the local site of the injury or the impact. ROM is painful or you cannot assess the pain, ROM. And acute presentation post trauma and fall. You are looking at a picture of traumatic spine fracture. Now, whenever there is tenderness in spine, there you are looking at a picture of either trauma, tumor or infection. So whenever there is history of fever or constitutional symptoms, you are looking at a picture of infection along with pain, right? When there is history of weight loss or other significant associated factors, you are looking at a tumor picture. And trauma, the history says everything, right? And in degenerative disease of spine, there is usually no tenderness. In degenerative disease, there is usually no tenderness. Tenderness is present in these three conditions, right? Now, what is the emergency alarming sign medico-legally? If you do not want to do some negligence, the only question that is most important is asking the history of bowel bladder disturbances and progressing neurodeficit. So whenever these two factors are there, it is a picture of emergency or alarming which might require a surgical intervention. You should not miss to ask these questions, right? Now, so we are done with the basic history taking. We have understood the differentials, 4 to 5 important factors which clinches to the diagnosis, bang on provisional diagnosis of what the case is. So all these we have done. So now let us go to the spine OPD. 4 to 5 patients are waiting for us, right? So the first case, without further ado, let us begin with the first case. And now you are going to answer, not me, right? So the first case, she is a 65 years old lady. 65 years old lady does mean postmenopausal, more of osteoporosis picture or LCS picture, right? Came to the OPD with complaints of low back pain with right lower limb radicular pain since 2 years. 2 years, both radicular and low back pain. 2 years is a very significant thing. Now, she complains of inability to walk. When she says that I am having low back pain, right lower limb radicular pain, on asking further aggravating symptoms, she says that she is unable to walk for more than 5 minutes, and she is a 65 years old lady, housewife. She says that when she goes to the kitchen for cooking, she is not able to cook in the kitchen due to pain which she was able to do 2 years back. This is very significant. She is unable to walk, she is unable to stand. What does it mean? The next question you ask is, what relieves the pain? She says that after sitting, the pain gets relieved. This is the classical picture of neuroclaudication. And the second line, the second component of the line is also very important, which she is having these complaints after 5 minutes and 10 minutes, but she was able to do it 2 years back. That does mean that the neuroclaudication is progressing. She also says that while sitting, she keeps her knees flexed. And she keeps her knees flexed. That is very important, significant finding of LCS when flexion is relieving. So knees and hips are flexed. That relieves the pain. And while walking, the next thing she says is while walking, she feels that her footwear slips. So there is some neurodeficit at the foot. And toes, right? On further examination, the positive finding on this case is right-sided L4, L5 power and sensations decrease. So the positive points, first is 65 years old female, right? This is the first. The second is 2 years, significant history. The third is progressive neuroclaudication. The fourth is the flexion is relieving the pain. Fifth is there is some neurodeficit. And on examination itself also it is saying that some neurodeficit. So it is a picture of neuroclaudication. Along with that, the flexion is on flexing the knee, she feels better. So it is a picture of LCS with neuro deficit, and the LCS is a progressive course. The LCS has a progressive course because 2 years back the neuroclaudication was less, which is increased. And on examination also you can find some neurodeficit. So this is the flow chart you follow. So there is some LCS with some neurodeficit. So you confirm on X-ray and MRI, and it is after confirming the diagnosis and after discussing with the patient, a surgical intervention would be advised for this lady. So this 65 years old lady, you will advise her after confirming and discussing, you will advise her for a surgical management, right? So this was the first case. Now let's suppose this lady is not willing for surgery. We go for a second case. The second patient in OPD, a 45 years old gentleman, enters the OPD and says that I am having bilateral low limb radicular pain, right more than left, tingling and numbness with low back pain. But I'm asking, you ask whether low back pain is significant or low limb radiculopathy is significant. He says that low limb radiculopathy is very significant, right? Then he says that his pain is on asking the aggravating factors. He says that his pain is continuous, but when he bends to tie his shoelaces, he has severe pain. These are a few of the things which clinches the diagnosis. Flexion is painful. Lower limb radiculopathy is more. We are looking at a picture of. I am not going to answer. You answer. We are looking at a picture of Pivd, right? Now he is not able to sleep since 4 to 5 days, so his daily life is getting affected. A Pivd picture. And the next thing, the alarming thing, he says that he has some urinary urgency since 2 to 3 days. Alarming picture, right? And additionally, he says that his pain, on asking further, he says his pain increases on sitting from sleeping position and in bed turning. So there is some component of listhesis as well. On examination, list, classical finding, Pivd. List points to the Pivd. SLR slump test, nerve root stretching test is positive, Pivd. And right sided foot drop is present, Pivd. There is some neuro deficit. So the points clinching to the diagnosis is, first things, lower limb radiculopathy more than low back pain. Second is flexion painful. Third is there is sleep disturbances. His or her daily life is getting affected. Alarming sign, urinary bladder disturbances. Most important sign, examination, list is positive, nerve root stretching is positive, and foot drop is present. So we are looking at alarming case of Pivd with bowel bladder disturbances with some neuro deficit. We are looking at a picture of Pivd, progressive Pivd, with affection of daily life, with some neuro deficit, and with examination findings positive, right? So this is the picture of Pivd. MRI, so we'll directly, in this case, we won't go for X-ray, we won't wait for an X-ray, we'll go for an MRI, and after confirmation of diagnosis, we won't follow this protocol. I'll ideally directly go for a surgical management. Why? Because there is history of bowel bladder disturbances, right? Whenever there is history of bowel bladder disturbances, it is better to go for a surgical intervention, right? So this was the second case. Now the third case. She is a 79 years old lady. Age significant for osteoporosis lady. 25 years post hysterectomy status. High likely osteoporosis. She came with the complaints of low back pain after a trivial fall leading to pain. More likely osteoporotic compression fracture 5 days back. Now she also says, most important thing to ask when you are suspecting, when a lady, 79 years old lady, 25 years of hysterectomy, complaining of trivial fall from just bed, slight fall from bed and leading to the low back pain. at that time. Slight, just fall from bed or on flexing the knee. Just fall from a small height like bed, leading to low back pain. Acute presentation is more likely a osteoporotic compression fracture picture. Right? The thing you need to ask in this case is history of multiple fracture in the past. She says that she had a fracture around the left hip for which a plate was put in operation theater 4 years back. History of multiple fractures in the past. On examination, tenderness is present at L4, L5. ROM is painful. What are you suspecting? I won't answer. You answer. You are looking at a picture of osteoporotic fracture. Right? So the first thing is 79 years old lady, old age, female, sex, 25 years old, 25 years post hysterectomy. Acute presentation post a trivial fall. History of multiple fractures in the past. Midline tenderness present. ROM painful. All these 7 factors clinching to the diagnosis of osteoporotic fracture. So what is the flow chart? What is the flow chart? If there is some neurodeficit, we can straight away go for surgical management. If there is no neurodeficit, then we might go for a calcitonin, calcium vitamin D supplementation, or directly vertebroplasty. If there is no significant pain relief, we might go for a MRI to look for non-union instability, following which surgical management might be required. So this is a picture of osteoporotic compression fracture, right? And the last case for today, the last OPD patient for today is a 35 years old. So the fourth patient, 35-year-old bank manager, young patient, bank manager, less exposure to sunlight, comes to the OPD with low back pain since 15 days. A very not significant duration, right? He says that he is irritated, saying that he is young and fit, follows his religious fast and eats vegetarian food and does gym regularly. But still he is having pain in back which is on and off in nature since many years. Sometimes upper, sometimes mid, sometimes lower back pain. He also says that he had taken some vitamin supplements as advised by his general practitioner friend on WhatsApp, and he feels good. But the pain recurred after a few weeks. After a few weeks of stopping the supplements, on taking the supplements, he was feeling better. But he's on asking whether he is able to sleep or whether the pain is significant. He says no, that is not that significant. He is able to sleep, and neuroexamination is essentially normal. So what are you suspecting? A young patient of having the bank less exposure to sunlight, a short duration, not that significant. He says that, and eating vegetarian food, that is the third significant thing. Does gym but regularly is having pain on and off in nature. The pain is on and off in nature since many years. The site sometimes upper, sometimes lower, sometimes mid door. The site is changing. All those things. History of taking some vitamin supplements in the past, following which he was better, but then the pain recurred. The radiculopathy is not that significant and there is no neurodeficit. All these points suggest, what does it suspect? What does it suggest? Suggest a picture of vitamin D deficiency, as we had discussed in detail. Less exposure to sunlight, vegetarian diet, on and off in nature, pain is on and off in nature, the site is on and off, the site is changing, history of taking vitamin D supplements in the past, and not that significant radiculopathy with neuroexamination normal. You are looking at a picture of vitamin D deficiency. No need to explain the vitamin D deficiency treatment, we have already discussed in detail, right? So this was the concept of how do we reach to the provisional diagnosis, how do we understand logically what actually the patient is before getting the investigations done, before getting the X-ray and MRI done. When is MRI warranted, when is X-ray warranted, when is emergent surgical management warranted. All these factors I hope we have discussed in detail and you understand the concept. This was Dr. Mihir Tejura signing off with simplifying the art of reaching to the provisional diagnosis, just the spinal way. Thank you so much, guys.